بنبدأ السيشن في السكند داي. السيشن بتاعت النهارده الكارديوفاسكولار ايميجينج. يعني بداية طبعا بنشكر اللجنة المنظمة لمؤتمر الأشعة لجامعة عين شمس، وعلى رأسهم أستاذ دكتور محمد أبو الهدى والتيم اللي معاه، اللي ما شاء الله مجهزين برنامج على مدى يومين، برنامج رائع وافي مغطي جميع السبيشاليتيز. احنا برضو عشان الوقت بتاعنا نوفر الوقت هنبتدي نشتغل على طول كده ونقول كده. طبعا انا برحب بوجودي كشير بيرسون مع استاذ دكتور وحيد طنطاوي والاستاذ دكتوره سميره سرايا. استاذ دكتور وحيد طنطاوي طبعا زي ما كلكم عارفين من البيونير في الكاردياك ايميجينج في مصر، ومن الناس اللي وداعمين للسبيشاليتي على كافه يعني ايه هنقول مستويات الاكاديميه والعلميه والادبيه. طبعا استاذ دكتور وحيد طنطاوي استاذ اشعه بكليه الطب جامعه عين شمس، وهو رئيس المجلس العلمي للزماله المصريه، وكمان هو نائب رئيس المجلس العلمي للزماله العربيه. اتفضل.
شكرا for the introduction يا دكتور رجب من برضه البايونيرز، وكذلك الدكتوره سميره في الكاردياك الحقيقه. وهو يمكن اول جامعتين ابتدوا كاردياك ايميجينج كانت القاهره وعين شمس الحقيقه، واحنا مبتدئين يمكن من سنه 2003 2004 الكاردياك ايميجينج. ومتهيألي شو يعني الجامعتين ووراهم جامعات الاقليميه الاخرى قطعنا شوط كبير قوي، وعملنا جمعيه الكاردياك راديولوجي او كارديوفاسكولار راديولوجي، ايجيبشن سوسايتي اوف كارديوفاسكولار راديولوجي. ويعني عملنا مؤتمرات كتيره، منها مؤتمرات كانت كاردياك بس، والامور الحمد لله يعني انا شايف احنا قطعنا باع في ان احنا نثبت اقدام الراديولوجي في الكاردياك، اللي هو يعني في تيرف باتل قويه جدا. والحمد لله بقى لينا يعني فوت برينت كويس جدا الحمد لله. طبعا حته السكند كارديوفاسكولار ايميجينج ده ما اعرفش معناها ايه، ملهاش معنى، متهيألي في غلطه. هو ده الناينث كونفرنس لاسم الاشعه، وما فيش اي حاجه فيها سكند، لكن يعني anyway يعني نرحب بالجميع الحاضرين وبالمشاركين في التوكس، ونشكر المنظمين للمؤتمر، وان شاء الله الكل يتمتع ويستفاد من السيشن دي. اول توك هتبقى Acute Chest Pain MRI رول. هنتكلم عن Acute MRI وتاكوتسوبو ومايوكارديال، متهيألي دي مايوكاردايتس يمكن. ودكتوره شيماء صلاح هي اللي هتدينا التوك. اتفضلي يا دكتوره شيماء. ازيك؟
Good morning. I am Shaima Salah, lecturer of Radiology at Ain Shams University. First, I would like to thank the organizing committee and the chairpersons for giving me this opportunity. I would like to thank our mentors, Dr. Professor Dr. Wahid Tantawi and Dr. Ahmed Samir, for educating us this knowledge. Today, we're going to talk about the role of MRI in acute chest pain. Acute chest pain, a patient comes to the ER with acute chest pain. There is different causes. Could be myocarditis, could be pericarditis. We have other causes like pulmonary embolism, pneumonia, pneumothorax. It can be esophagitis, esophageal rupture, also aortic dissection, many differentials. The clinician start by clinical evaluation, ECG, lab, cardiac biomarkers to reach the diagnosis for proper treatment. We have the life-threatening conditions, the cardiac causes, and the acute coronary syndrome. It has to be excluded. Life-threatening condition that also can be mimicking other causes like myocarditis and Takotsubo cardiomyopathy. MRI can help in dealing in such situations. First, we're going to talk about the acute coronary syndrome. On the basis of the ECG, if myocardial infarction is diagnosed, urgent reperfusion should be done. Then the American Heart Association have classified the patients according to their likelihood of having coronary artery disease into intermediate risk, high risk, and low risk patients. Patients of intermediate risk can go for imaging, functional and structural, as CT or MRI. Also, this imaging is done in patients where the ECG changes are non-equivocal, where the biomarkers, cardiac biomarkers, are not such elevated, in cases undifferentiated cause of acute coronary syndrome or not. So the potential role of cardiac MRI in the acute phases is its risk stratification, patient with coronary artery disease, improve the sensitivity in detection of unconfirmed cases like non-STEMI or unstable angina, and exclude other causes of acute chest pain. Also, MRI can be used in cases after the PCI. The European Society of Cardiology have recommends using MRI in some cases after the percutaneous coronary intervention. In cases in early phase, if the echo is unequivocal or unsatisfactory results after the reperfusion, persistent symptoms, patient with heart failure, or also can be done delayed in the late phase after 6 weeks of the PCI in case to assess the left ventricular function, to assess the heart, the scar after reperfusion, in cases of persistent symptoms and elderly patients. How can MRI can help? First, we have the cine images. We have short axis view and 4-chamber view for ventricular volume assessment, systolic functions for both LV and RV, assessment of valvular stenosis or regurgitation, any wall motion abnormalities. Then we have the T2 star images for detection of edema, where acute MI have edema and chronic conditions, there is no edema. Then contrast injection is done, and here come the late gadolinium images. We have the late gadolinium images with many answers that could give us. First, the transmurality of this scar and this infarction and the scar size, from which we can define it as ischemic cause or not. Ischemia is subendocardial infarction with coronary distribution. We have is enhancement in subendocardial infarction with coronary distribution. We assess it if it is subendocardial or transmural infarction. Also, we can assess the scar size, quantify it, the scar size by the software. Quantitative assessment of the scar size is inversely proportionate to the prognosis of the patient. When the scar size increases, the remodeling is more, and so it's poor prognosis to the patient. Then the microvascular occlusion, which is the no reflow phenomena, area of no reflow. In the late area of enhancement of the scar, there is core of the infarct with no reflow after reperfusion, no flow in this area, which is bad prognosis to the patient and poor prognosis and means adverse remodeling. In the late gadolinium images also we can assess the myocardial salvage index, where we compare the images in the T2 star to the images in the late gadolinium enhancement. The difference in the size between the edema in the T2 star and the scar tissue infarct size in the late gadolinium enhancement is the myocardial salvage, the myocardium that could be saved by the reperfusion. We also have the strain analysis to assess the contractility and any wall motion abnormalities. It's better and more sensitive than the ejection fraction. Provide prognostic value over the ejection fraction alone. It could be done either by myocardial tagging or feature tracking, which is a technique using the cine images and with the software to obtain the strain analysis of the myocardium without adding extra sequences to the patient. Also, MRI can help to define complications in the acute setting, acute MI, as intracavitary thrombi or aneurysm, pseudoaneurysm, wall rupture, RV infarction, or mitral regurg. Also, we have the stress perfusion to assess the coronary flow capacitance, detect any perfusion defect or ischemia, It will be explained more with Dr. Rana. Come to our next entity, the Takotsubo cardiomyopathy. It's a syndrome of wall motion abnormality which is detected in elderly female. This wall motion abnormality could not be explained to the corresponding coronary artery occlusion. There are diagnostic criteria to the Takotsubo from the European Society of Cardiology and the revised Mayo Clinic criteria, explaining that we have wall motion abnormality. Any coronary lesion could not explain this wall motion abnormality. The patient have elevated cardiac biomarkers, elevated natriuretic peptides. The patient recover after a period of time, and left ventricular dysfunction is improved. How can MRI help? This regional wall motion abnormality could be detected in the apex of the heart, or mid-ventricular, or even basal, reversed Takotsubo. Also, we can quantify the left ventricular functions, left ventricular volumes. We can assess the RV. Some cases it come biventricular, and there is RV ballooning. The strain analysis could help in cases of Takotsubo. Here we have the wall motion abnormality in the apex. However, preserved wall contractility in the short axis, in the mid segment, and in the basal segment. Tissue characterization for detection of edema, fibrosis, or necrosis. Here, the T2 star images detect the edema, the basal segment to show no edema. However, in the mid and the apical segment, there is edema where the ballooning seen in the 4-chamber view, the apical edema. Then also we have mapping. In this patient, it has basal ballooning. Case of Takotsubo's basal ballooning. The base of the heart show elevated T1 relaxation time in T1 mapping. Additional abnormalities that could be found in the case as pericardial effusion, pleural effusion, intracavitary thrombi also could be diagnosed. Then we have myocarditis, acute myocarditis, acute inflammation of the heart with different etiologies. The different etiologies could be infectious, immune-mediated, or toxic. The clinical presentation could be chest pain, palpitation, or could reach cardiogenic shock and ventricular arrhythmia. The current European Society of Cardiology and the American Heart Association consider CMR useful in the evaluation of myocarditis. Here, the CMR help in diagnosis and also provide information on the prognosis of the case. In case of myocarditis, we have edema and hyperemia. It's an inflammation, edema, hyperemia, and injury and scar. Additionally, there is wall motion abnormality and pericardial effusion. But mainly, it's an inflammation, edema, hyperemia, and scar. So edema, which is detected on the T2 weighted images, hyperemia on the T1 black blood images, pre and post contrast, we see increased hyperemia in the early gadolinium images, and also scar في late gadolinium images, there is enhancement with scar tissue following, in this enhancement follow the non-ischemic pattern that it is subepicardial or mid-myocardial in non-coronary distribution, like here, and this in short axis images subepicardial, so we diagnose the myocarditis. We have the Lake-Lewis criteria. The Lake-Lewis criteria, the original criteria was depending on the T2 and the early gadolinium image and the late gadolinium images for the diagnosis of the myocarditis. It's diagnosed 2 out of 3. The updated 2018 depend on the T1 based images or T2. T1, we depend on the native T1, increased T1 value, increased ECV and late gadolinium images, and T2 increased T2 map or T2 edema. Supportive pericarditis with diastolic function. In comparing the Lake-Lewis criteria, 2018 have higher sensitivity in compared to the original Lake-Lewis criteria. An example here, in case of myocarditis, we have epicardial enhancement, edema, field stare images. He has elevated T2 relaxation time for T2 maps and elevated T1 value, so it's a case of myocarditis. Take-home messages: cardiac MRI has wide imaging sequences with better understanding different pathologies. Acute MRI the CMR help in the acute MRI to quantify the myocardial salvageable index, detect the mesenteric vascular occlusion, also in the prognosis of the patient, and MRI can help detect differential diagnoses such as myocarditis and Takotsubo cardiomyopathy. Thank you.
Thank you دكتور شيماء. لو في سؤال كده سريع، ما فيش مشكلة، حد عايز يسأل حاجة؟